or would you like to wait another minute or two?
I'm all set whenever you are. You bet.
Okay, cool. Well, it is my pleasure to introduce Dr. Carolyn Major, though most of you probably already know her from being also our moderator at WooU. She is a professor and director of residency programs at the Northeastern State University, Oklahoma College of Optometry. She's also a fellow of the American Academy of Optometry and Optometric Retina Society. She received her doctorate of optometry from the Pennsylvania College of Optometry at Salus University and completed an ocular disease residency at the Eye Institute of the Pennsylvania College of Optometry. So we can't wait to hear from you, and I'll have you go ahead and take it from here.
Thank you so much. And I want to thank Wu University and Zeiss for having me here this evening. And, very tough to follow such an excellent lecture. We're going to talk even more about how to use your Zeiss Cirrus OCT and OCT angiography with Angioplex in order to best care and assess your patients with diabetic retinopathy. And I'm a huge proponent that the multimodal imaging era has come and it is here to stay, right? We need to do more than just OCT angiography for our patients with diabetes. We also need to consider color fundus photography, especially wide field and ultra wide field imaging, B-scan imaging, fluorescein angiography as needed. So multimodal imaging really gives us more of a holistic approach in caring for our patients with diabetes. And I want to mention too, make sure you stay tuned for the entire presentation because at the very end, Zeiss is going to have a QR code that we're going to have a special discount or offer for you on OCT and geography if you mention Wu University. So make sure you stay tuned for that at the very end of the presentation. And so I want to kick this off, by humbling myself really and saying things that I've missed on my clinical examination that OCT and OCT angiography have actually picked up. So diabetic retinopathy addition. We know that OCT, especially OCT angiography, provides such high resolution microvascular detail that it's going to pick up and highlight vascular abnormalities that we can't see on clinical examination alone. And those may be areas of non-perfusion, areas of IRMA or microaneurysms. That's going to allow us to get a better picture of what's really going on in the retina so we can more accurately stage that patient's diabetic retinopathy, as well as predict what is their risk of developing vision-threatening complications in the future. I want to kick this off with this patient and say, how are we going to stage this patient's diabetic retinopathy? So here we have the wide field color fundus photography from Claris, the Zeiss Claris device. We can see this patient has extensive intraretinal hemorrhaging in all four quadrants, but I'm not seeing anything that would scream at me that this patient is proliferative with regards to neovascularization. There's no preretinal vitreous hemorrhage. So just based on the photography thus far, and clinically when I examine this patient, this is probably like severe non-proliferative diabetic retinopathy. We need to think then what scans are going to be needed in this patient. We have OCT, we have OCT angiography, Angioplex available. What is going to benefit us in the assessment of this individual? We know individuals that have severe non-proliferative diabetic retinopathy are at an increased risk of developing proliferative retinopathy. About half of them in 1 year will become proliferative. So I want to make sure I'm not missing proliferative disease right now. And I think a great way to do that is getting a montage OCT angiogram. And so this montage was acquired by doing an 8mm montage on the Angioplex device. And what I did was I took 5 separate 8mm cube scans. They then knitted together, the resultant image being 14mm by 14mm. And we can see what I was missing in this patient was areas of non-perfusion out in the mid-periphery. There also was an area that looked like IRMA in the inferior nasal aspect of the retina. But what was really impressive is when I took out just the superior temporal 8mm cube of that montage and analyzed it, there was a teeny tiny area of neovascularization elsewhere that I had missed on my clinical examination. And anytime something shows up on your vitreoretinal interface or VRI on your Angioplex device, you want to cross-section through it to see, is there something sticking up out of the retina, which we would presume to be pre-retinal neovascularization. And indeed, we can see this little nubbin of tissue kind of sitting up on top of the retina, confirming for us this patient actually has early proliferative diabetic retinopathy. I referred him to a retina specialist, and he ended up getting PRP. I want to highlight that you don't need OCT angiography necessarily to see pre-retinal neovascularization, because even on structural examination, there's clues that there's neovascularization there. Because neovascularization usually grows up out of the retina, so we can actually see that tissue, and it tends to crawl across the posterior hyaloid of the vitreous. When we have neovascularization on the disc, it almost like hangs across the cup like a hammock. And so this sort of appearance of a hammock hanging across the cup is another like telltale sign from a structural OCT point that you're probably dealing with neovascularization. So when I see things like this on the structure, I'm going to go and then do an OCT angiogram with Angioplex in order to better image those specific areas to see if they are perfused and vascularized. I want to highlight that neovascularization usually grows on the border of perfused and non-perfused retina. And look at how most patients with diabetes, this border is going to be out in the mid-peripheral retina. And so we really need to be getting that montage and imaging out in the mid-periphery in order to visualize these areas of neovascularization. We also can use our montage imaging to separate out and isolate neo using that vitreoretinal interface preset. So in the vitreoretinal interface, we can isolate out very easily, very quickly and efficiently areas of neovascularization. So I can say, well, yeah, this patient is proliferative. I need to refer any patient with new onset proliferative disease to retina for consideration of PRP or perhaps anti-VEGF therapy. Something else I miss on clinical examination, anyone can't really see when it's chronic is retinal non-perfusion and ischemia. This was a patient that had type 1 diabetes, obviously proliferative. There's a huge front of neovascularization up there superiorly. But what I couldn't appreciate on clinical exam was that this whole area was non-perfused retina out in the mid-periphery. And so we know retinal non-perfusion is almost invisible on clinical examination. We need some form of angiography, whether it's OCT angiography or IV fluorescein angiography, in order to visualize the true extent of retinal non-perfusion present. And OCT angiography is so good and has such good detail that we can actually detect pathology in the retina before it presents to us clinically. So about 1/3 of patients that have diabetes but do not yet have diabetic retinopathy on clinical examination will have abnormalities on OCT angiography. So an enlarged foveal vascular zone, microaneurysms, or small areas of non-perfusion are these early changes in pathology that we see in patients with diabetes before they develop mild non-proliferative disease on clinical exam. We know that the deep capillary plexus preset takes a little bit more of a hit in terms of retinal non-perfusion in patients with diabetes than does the superficial capillary plexus. But macular ischemia may be accounting for a decrease in best-corrected visual acuity, especially in patients that don't have center-involved diabetic macular edema. So when we have enlargement of the foveal vascular zone or an irregular contour, a break in the perifoveal capillary ring that usually goes around the foveal vascular zone, you want to suspect that you're dealing with macular ischemia, which is unfortunately an irreversible process. There's no treatment for that, and it would decrease the ultimate visual prognosis for that patient. This is another one of something I missed on clinical examination, a patient with mild non-proliferative diabetic retinopathy that had a mild central cyst, so subclinical diabetic macular edema. Certainly, I can't see this microcyst with clinical examination alone, and OCT really adds value in detecting the earliest changes possible when patients are still asymptomatic. And kind of going into this diabetic macular edema realm, I want to make sure we touch on staging. So we've gone away from CSME and we're going towards the terminology that OCT dictates, which is center-involved versus non-center-involved diabetic macular edema. And so center-involved diabetic macular edema is thickening within this central subfield zone, which on the Zeiss Cirrus 5000 model printout, it's this central circle here, which is a 1 millimeter diameter zone. If you have thickening within this region, which is light yellow or pink on your machine compared to the normative database, you're dealing with center-involved diabetic macular edema. So here's an example of a patient that has non-center-involved diabetic macular edema, so a circinate ring of exudates in the superior temporal aspect, but the central subfield zone is green within normal limits. Here's a patient with center-involved diabetic macular edema. We can see the central subfield zone is pink. We have sort of this pocket of intraretinal fluid approaching from the temporal side and actually involving the center of the fovea. So we have intraretinal fluid here, along with these hyperreflective dots, which are exudate, and we can see them clinically on the color fundus photography here as well. Structural OCT can also be very valuable in helping you say, what is the status of the posterior hyaloid? Patients that have a complete PVD is protective because neovascularization doesn't have anything to grow onto, and there's also less risk of tractional complications like vitreous hemorrhage or tractional retinal detachment. It's these patients that have these like partial posterior vitreous detachments that you really need to worry about in terms of there could be tractional effects and patients could have detachments, hemorrhages, etc. Structural OCT is a great way to monitor patients with vitreoretinal traction. So, even with good PRP, this tissue became avascular. It's this fibrotic tissue. This is now just a mechanical pulling problem, right? A patient that may benefit from vitrectomy, but we can closely monitor them in conjunction with retina to see if things are getting worse, their subretinal fluid, referring them back for consideration of vitrectomy. I think another interesting, and my patient population unfortunately affords me this opportunity, is to use structural OCT when you have a tractional retinal detachment to say, is it involving the macula or the fovea, or is it threatening the fovea? Certainly, if you have a non-macular detachment that's threatening the macula, that would be a more urgent referral. In this particular case, you can see this patient had subretinal fluid and a tractional retinal detachment involving the very center of the fovea, hence the 2150 vision. I'm going to wrap us up here with a case. So this was an asymptomatic 41-year-old male, and he was coming in just for his routine diabetes examination. He's had type 2 diabetes for 20 years, very poorly controlled with an A1C of 14%. His best corrected visual acuity was slightly reduced in the right eye to 20/30 plus 2, and the left eye was 20/20. As we can see here from the Zeiss Claris True Color Ultra Wide Field Imaging, so this is 200 degrees in horizontal diameter, this image, and this was two captures that were montaged together to get this image. You see there's some extensive intraretinal hemorrhaging, and it extends out into the mid-periphery. So when you have intraretinal hemorrhaging and diabetic retinopathy lesions that extend out into the periphery, that's usually higher risk, more severe retinopathy presentation for potentially developing proliferative diabetic retinopathy in the future. It also has a lot of cotton wool spots, so we're probably going to see a lot of non-perfusion on our OCT angiography coming up here in a second. Another feature I want to point out that we captured on our ultra-wide field imaging was this peripheral vascular sheathing, which is another sign that there's going to be massive retinal non-perfusion when we do our OCT angiography montage. Really severe retinal ischemia driving future proliferative disease. So here's the 14 by 14 millimeter OCT angiography Angioplex montage, and we can see there's massive non-perfusion in the mid-peripheral retinal lesion. I wanted to put this in contrast with a normal patient, so you could see how severe this loss of the retinal capillaries in the mid-periphery really is compared to what we would expect in a normal healthy individual. Anytime you have these massive areas of retinal non-perfusion, this is retina that's dying off and it's releasing VEGF. And as it's releasing VEGF, it's stimulating that growth of proliferative diabetic retinopathy. So when you're seeing this degree of retinal non-perfusion, they're either already proliferative, we just need to find the neo, or they're going to develop it very quickly, probably within the next 6 months in this patient's particular case. And certainly a patient that has this degree of retinal non-perfusion, even if they truly are non-proliferative, are probably going to benefit from some early intervention, whether it's PRP or anti-VEGF treatment. So this degree of retinal non-perfusion should definitely warrant a referral to a retina specialist for consideration of therapy. What else was present in this patient's eye, superior temporal, was this area of abnormal vasculature. And so my question is this IRMA, intraretinal microvascular abnormalities, or is this neovascularization elsewhere in the retina? With our volumetric 3D cube of data we get with OCT technology and OCT angiography, we can easily make that determination. And so what I did is I used my little navigator to cross hair right through that abnormal vasculature. And I could see that it was still in the retina. So this is intraretinal microvascular abnormalities. It also didn't show up on my VRI or vitreoretinal interface. So again, I'm confirming this is just IRMA, intraretinal. It is not neovascularization. So this patient's right eye likely has a diagnosis of very severe non-proliferative diabetic retinopathy. Interestingly, this retinal non-perfusion tends to progress over time. And so if we compare his Angioplex OCT angiography montage from 15 months ago to today's examination, we can see how these areas of non-perfusion have really increased in size and progressively mounted over time. And again, once retina is dead and it's non-perfused, we can't bring it back. So ultimately, early diabetes control is the most important thing to decrease the risk of progressing and mounting retinal non-perfusion. Here's his macular OCT in the right eye. You can see he has some non-center involved because the central subfield zone is normal. So some non-center involved diabetic macular edema with some intraretinal cysts, as well as some exudate here, primarily within the temporal aspect of the retina. So our question is, why is his vision 20/30 when the center of the fovea is looking pretty good, right? And that's going to prompt you to say, I need to do OCT angiography, angioplex of the foveal region. So I'm now going to go and do a 3 mm cube right on the center of the fovea to look for macular ischemia that's probably accounting for that 20/30 vision. And indeed, here it is. So in our superficial capillary plexus, we can see there's this break or sort of like disruption of the foveal vascular zone and the peripapillary capillary like ring. And we can see these areas of non-perfusion, especially in the superior aspect of the macula here. It's likely accounting for this patient's decrease in best-corrected visual acuity. And here's the patient's left eye, pretty similar presentation. Remember, this eye actually was seeing a little bit better, 20/20 vision, despite this sort of horrific color fundus photography type of appearance. Multiple intraretinal hemorrhages, many cotton wool spots, cluing you in there's going to be massive ischemia that we're going to see with angiography. And as I mag up, what's really great about the Claris True Color Ultra Wide Field camera is that you get all this peripheral data, but you can also magnify and still get really great resolution of the posterior pole and optic nerve. So you can start to see it looks like there's neovascularization on the disc, as well as a lot of exudate and IRMA in the temporal macular region. Here's an OCT angiography scan that I've done just on the optic nerve head because I suspected that there was neo on the disc here, but it's pretty subtle, right? And so I'm able to tease out right here, there's definitely neovascularization on the disc, probably about 1/4 disc area in size. On structural OCT imaging, we can also see it too, this little plug of tissue that's connecting to the posterior hyaloid. So indeed, we have proliferative diabetic retinopathy in this patient's left eye, even more so warranting a referral for retina for consideration of PRP. So our assessment for this patient as an overall, the right eye having very severe non-proliferative diabetic retinopathy with non-center involved edema, and unfortunately significant macular ischemia. The left eye having proliferative diabetic retinopathy with non-center involved edema. Certainly the left eye warrants PRP therapy. We got to refer to retina within a reasonable time frame. Probably 2 to 4 weeks would be most appropriate for this patient's left eye. The right eye was probably going to benefit from early therapy as well. So we referred to retina. He actually didn't get there for some time, I think over 6 months. Something happened with the referral. But when he did get there, he actually had neovascularization on the disc in the right eye, which we could have predicted because of all that mid-peripheral non-perfusion. And here he is at his 2-year follow-up. So he got panretinal photocoagulation, but there's still some traction from this partial PVD that's pulling on neovascular tissue and causing a recurrent vitreous hemorrhage in this patient. What's great is we can use Zeiss form review software, and this is the macular thickness analysis that allows us to simultaneously view 3 macular cube scans over time. So this was his baseline examination, then 2 years and 3 years out, as we're co-managing him with retina, and we can actually see this macular edema has improved over time. We also get quantitative trend lines. So the green line here is the average cube thickness, and we can actually see his average cube thickness has been improving with his retinal treatments over time. Here's the left eye, which remember this had neovascularization on the disc on baseline examination. He ended up getting PRP, as we can see here on our ultra wide field scan. He developed a little bit of an epiretinal membrane, but his vision only declined from 2020 at baseline examination to 2025. Unfortunately, he ended up developing neovascular glaucoma, but we were able to get him in promptly with a glaucoma surgeon and got a tube shunt and was able to maintain good vision in this patient's left eye. And with that, I'm going to conclude and happy to take any questions. And please, if you're interested in OCT angiography and Angioplex, scan the QR code here and mention Wu University for a special offer on Angioplex OCT angiography.
Awesome. Thank you, Dr. Major. So let's go ahead and go into some of our questions here.
Sure.
One of the questions was, do you need to dilate patients for OCTA?
It's not required, but I find that you sometimes get better scan quality when you do, especially if it's like an older patient that has myotic pupils to begin with. It's going to give you better scan quality and allow you to put the motion tracking on, because the motion tracking is a really important component of getting a good quality OCT angiography scan because we're trying to track red blood cell motion. So if there's any motion artifacts, they could, interfere with your ability to get a good scan. So dilating is going to be better, but it's not required.
Okay, great. And then how often do you find that you would like to repeat OCTA imaging on patients?
It depends on the clinical scenario. So if it's a patient that truly has severe non-proliferative diabetic retinopathy, I've done a montage OCT angiography scan to confirm that they're non-proliferative. That's someone I'm probably going to monitor every 3 months. And if when they turn proliferative, then refer them to retina. If it's a patient that, say, maybe is already seeing retina, they've already had panretinal photocoagulation, they have stable areas of neovascularization, maybe every 6 months to a year. I'm usually only doing color fundus photography every 6 months to a year, again, depending on the clinical scenario.
Great. Do you ever use OCTA for any of your low tension glaucoma patients to possibly detect for peripapillary non-perfusion?
A great question. It kind of getting out of the diabetic retinopathy realm, but I don't mind at all. So yeah, there have been some good studies to suggest that patients with glaucoma in general have decreased peripapillary retinal radial peripapillary capillary plexus non-perfusion that you can detect with OCT angiography, and that may be valuable in helping you distinguish between, say, like ischemic optic neuropathy and glaucoma. But at the moment, it's not something I'm doing routinely, but it is another tool you have in your tool belt, especially to monitor progression of glaucoma over time, I think can add value.
Great. And then would you know if insurance would possibly cover billing OCT or, OCTA if there was no sign of diabetic retinopathy?
I think you have to have a code of diabetic retinopathy in order to bill for OCT or OCT angiography.
Okay. Let's see here.
But that being said, I mean,
Um,
there are a lot of practices that are doing like, the patient out-of-pocket cost wellness or like screening examinations that I think, add a lot of value to your practice and patients see value in it as well. And so OCT angiography is really a key component of like an OCT wellness scan as I see it.
okay, great. There was a question in the Q&A. When you see significant cotton wool spots in the posterior pole, do you consider OSA, especially if patient symptoms indicate OSA based in the new study, OSA effects on diabetic retinopathy, diabetic macular edema?
That's a great, so obstructive sleep apnea, I think is the question they're referring to. I certainly, if
Okay.
I have a patient, like let's say has diabetic retinopathy that's been progressing significantly, but yet the A1C is like 7%, or they've only had diabetes for like, less than 5 years. I have no explanation as to why they're progressing. I'm going to look for those other like systemic risk factors that could be adding fuel to the fire. And obstructive sleep apnea is definitely one of them. If the clinical presentation is more cotton wool spots, say then like intraretinal hemorrhaging, then I would look for things like obstructive sleep apnea potentially. And Probably also consider like some screening labs in terms of like HIV, seeing if they're on interferon therapies, checking the blood pressure, which we do on every patient, but I also have access to the full medical record. I can go back and see what it's been, looking at the most recent CBC, seeing if there's concurrent severe anemia that could be contributing, that can also cause a lot of cotton wool spots in the fundus. But there definitely be other things I would think about, including obstructive sleep apnea. I think it's a great question.
Great. And then, does this particular instrument offer anterior segment imaging?
I have the Zeiss Cirrus 5000. And yes, it comes with anterior segment imaging. I have to say I don't do it too often because I pretty much live in the posterior seg realm. We use it quite a lot to do pachymetry on patients with glaucoma. You can also do like an angle to angle, like cross-sectional OCT that you can do like angle measurements in patients with narrow angle glaucomas. There's epithelial thickness mapping. So I don't really dive into that aspect of the eye, but yes, mostly for glaucoma, I do use the anterior segment imaging.
Okay. And I get he just added, but is it anterior seg OCTA?
Oh, no. As far as I'm aware, there's no brand of OCT angiography out there that has anterior segment angiography FDA approved right now in the US. I can't
Okay.
wait, but
Cool.
unfortunately not yet. You'd have to hack your OCT machine to do it.
It's funny. I was just telling Dr. Sapoznik that I learned a lot from her OCTA presentation because I'm usually doing front of the eye
Yeah.
imaging. So
The best
we'll
estimate not.
lean on each other.
Yeah. You can email me and I can put you in touch with somebody who's hacked like a Heidelberg if you want this person.
Okay, cool. Yeah, and I believe that we've answered all of the questions so far. If there are any other questions, please go ahead and put it in the chat or the Q&A.
There was a question early on about can you build a 92137 code for low tension glaucoma to detect peripapillary non-perfusion? And I think that code is only like retinal OCT angiography. So I think the answer to that is no. But try it and see if you get paid would be my advice. And then let the rest of us know.
Yes. Um, Another question was, do you like to recommend supplements to any of your diabetic patients?
Oh, absolutely. Yes. So, like I promise DVS, I do recommend to patients, especially if there's like mild to moderate non-proliferative diabetic retinopathy. I also would consider in that scenario, especially moderate non-proliferative, oral fenofibrate. And I usually talk to the primary care physician before like prescribing or recommending something like that. But for sure, I would consider both of those things to help decrease the progression to getting to a proliferative stage or to having vision-threatening diabetic macular edema.
Okay, awesome. And then do you have any experience with OCTA and AI analysis?
Nothing that would be commercially available at the moment. No. In research things that I've done in the past with OCT angiography and glaucoma, yes, to some degree.
Well, I think that's all that we have for now. So yeah, guys, be sure to scan that QR code, get that special Woo You offer for your OCTA. And thank you so much, Dr. Major, for just this really insightful presentation and helping us learn more about this Zeiss instrument. We really appreciate your time.
Oh, my pleasure. Thank you so much for having me.
All right, good night, everybody.
Good night.